But they then took a subset of their patients with chronic hyponatremia. When they tested them before the correction of the sodium, they had subtle gait and attention defects, and if they then corrected their serum sodium, that got better. If they took patients with chronic hyponatremia and let their sodium drift down, they saw these defects occur as well. And what was interesting is that the risk of falls occurred at any dose of serum sodium. So even those that had very low serum sodiums, it wasn't look like they had a higher risk of falls. You still saw a significant risk of falls or prevalence of falls in the patients that had mild hyponatremia. Other series around the same time, this from Hong Kong, patients with chronic thiazide-associated hyponatremia, and about 17% of them had falls as well. They also had confusion or vomiting that was much more likely as serum sodium went down to less than 115. So there are dose-dependent symptoms that you see in relatively chronic hyponatremia. Obviously, in this cohort, there was a mixture of both acute and chronic hyponatremia. People have gone on to look at this in more detail and shown that in ambulatory elderly patients with mild hyponatremia, I put in a table from the paper, the unadjusted or an adjusted odds ratio of a fracture was very significant for hyponatremia. And this has been taken even further by Joe Verbalis' lab, looking at an animal model of hyponatremia where they give rats DDAVP and give them free water. And this turns out to be probably the most potent model of osteoporosis that's available. So if you look at the hyponatremic rats, they have a significant reduction in bone density and bone volume. And you can see here, just looking, I think all of us can appreciate that there's much less tuberculi here. The bone is much less dense than it is in the control rats. And they've shown also in NHANES that in the larger studies of humans that there is this relationship between serum sodium and bone density. Chronic hyponatremia has neurological consequences and it has consequences in bone that we were really just beginning to understand. That leads us to this issue of how do we treat hyponatremia. And we'll talk about the management of acute symptomatic hyponatremia, which differs from the management of chronic hyponatremia. Far and away, fluid restriction is our usual response to chronic hyponatremia, but as I said, because thirst is inappropriately stimulated in these patients, that can be difficult. I find giving Lasix and salt tablets very effective in some patients with SIDH and chronic hyponatremia. You're inhibiting the countercurrent mechanism and you're repleting extruded sodium chloride with the salt tablets. Dimeclocycline is basically a principal cell toxin. You lose the V2 response. It's relatively effective, but unfortunately it's a renal toxin, particularly in people with liver disease, and can cause renal failure. And the new kids on the block are obviously the vasopressin antagonists. Hopefully we agree that the treatment of acute symptomatic hyponatremia can be life-saving. You need to give hypertonic saline. You need to measure their oxygenation with a blood gas. You need to look at a chest x-ray. If you have time, do CNS imaging to see if they have cerebral edema, but that should not delay therapy. They need supplemental oxygen. They should be given a loop diuretic, often because it's very difficult to persuade patients or physicians to give somebody with neurogenic pulmonary edema hypertonic saline without giving them a loop diuretic at the same time. You only need to increase the serum sodium by a few points in acute hyponatremia. This was shown very nicely in a study of the Marine Corps Marathon, where these participants who developed hyponatremia, where they had point-of-care serum sodium, almost immediately after giving them hypertonic saline, their symptoms disappeared. And it's said that just increasing the serum sodium by 4 to 6 points is usually adequate to combat the effects of acute hyponatremia. The rate of correction is an important issue. In acute, 1 to 2 milliequivalents per hour. If you correct by 4 to 6 milliequivalents or so, you should get rid of these acute hyponatremic symptoms. It's difficult to tell what you should do after that point, and we'll talk about a case at lunchtime. Chronic hyponatremia, the usual recommendations are less than 10 in the first 24 hours and less than 18 in the first 48 hours. And as we'll talk about in a case at lunch, some advocate even a more conservative approach in patients that are at a high risk of osmotic demyelination. There are many quantitative formulas that can guide your management of hypo and hypernatremic patients. The electrolyte-free water clearance that was developed by Bud Rose many years ago is more important, I think, in the hypernatremic patients, as we'll talk about at lunch, but can tell you how much this patient is gaining free water or excreting free water in the setting of hypernatremia. Nick Medias has a very popular equation looking at the infused sodium and the infused potassium minus the serum sodium over total body water plus 1. And that will tell you how much 1 liter of this particular solution will give you. The urine plasma electrolyte ratio can help you gauge whether somebody is likely to respond to fluid restriction. This is urine sodium plus urine potassium over serum sodium. If it's greater than 1 or 0.5 to 1 or less than 0.5, this can tell you how likely they're going to respond to water restriction. So if it's greater than 1, that means this patient is actually retaining free water as they excrete sodium and potassium. So those patients probably are not going to respond to water restriction, whereas if they have a much less ratio where they are excreting some free water, they may respond to fluid restriction. If you look in this very useful review, there are many of these formulae that are tabulated. The major caveat, though, is no matter how precise these are, you can't predict changes in the underlying physiology. Some experts, Rick Stearns, for example, say don't even bother calculating the deficit and how much you're going to give. Just give this amount and follow the patient and follow their serum sodium. So if you use these calculations, you have a very high risk of overshooting your treatment goal, particularly if you don't follow the serum sodium. And this was shown very nicely by Rick Stearns' group. They looked at patients who had been corrected their serum sodium with hypertonic saline, and they looked at the ratio between the predicted rise and what actually happened. So if the formula was perfect, the ratio should be 1. But it was far and away much higher than 1 most of the time. So these formulae don't work that well if you just sort of set the amount of hypertonic saline and then walk away. And you need to remember that as you're giving hypertonic saline, you are changing that particular patient's physiology, so they may correct at a very unpredictable rate based on what you're doing. I like using this sodium deficit, which is the old way of deciding in this beaker how much salt you want to give that beaker to raise the serum sodium. And I tend to sort of then cut it in half if I think that the physiology is going to change, and I follow the serum sodium very carefully along with the urine osmolality. So if you have a patient that you're giving hypertonic saline to and you see their urine osmolality rapidly drop, they're at risk of a rapid correction because they're excreting free water at that time, and you should back off on the hypertonic saline. So what do you do if you overcorrect a patient? And how do you treat a patient if they've, God forbid, developed osmotic demyelination? You can give DDAVP and D5W to re-induce hyponatremia, and there's good animal and human data that this is effective. Mostly case reports, of course, in the patients with the human patients. In animals, if you give myoinositol, which is one of these brain osmolytes, if you give it during correction, you can protect against osmotic demyelination. There's animal data that giving dexamethasone to restore the blood-brain barrier helps with osmotic demyelination. And there are many case reports, mostly from Asia, that use this a lot, but this is not considered appropriate clinical therapy at this point. Until a few years ago, if you were faced with a patient who had overcorrected, there were really only a few case reports where people had re-lowered serum sodium and osmotic demyelination with some success. And there would be a concern if somebody had hyponatremia, if you lower their serum sodium, they may develop a seizure. This paper, which was a retrospective analysis of about 20 or so patients who were given DDAVP to re-lower their serum sodium, showed that it was in fact quite safe. So this is a patient who went from 115 to 135, was given several boluses of DDAVP to re-lower her serum sodium. You can see the problem with this approach is sometimes you get an unpredictable response and they can go down even further. But then this was allowed to then go back to normal, and the net correction between 0 and 120 hours or so was reasonable. So this is now something that is routinely recommended by many experts. To re-induce or slow down the rate of rise of hyponatremia, you need to give back some vasopressin, which is DDAVP, and you need to give them varying amounts of free water. To get around this sort of herky-jerky approach, Rick Stearns had a case report last year, and they have a presentation at ASN on this approach, where they give large amounts of DDAVP, BID, and they give hypertonic saline to increase serum sodium at a more controlled rate. So going down, as we get more experience with some of these other measures, we may have a better way to gradually increase serum sodium in patients that have severe hyponatremia. And again, we have a case at lunch where we're going to talk about how we did this. Hyponatremic causes associated with overcorrection is another very important differential diagnosis. The key one is hypovolemic hyponatremia after volume resuscitation with saline, where you have a rapid drop in vasopressin. Remember that this half-life of vasopressin is quite short. Patients that have hypopituitarism with secondary adrenal failure, they have a euvolemic form of hyponatremia. If you give them enough cortisol to reduce their vasopressin, that can be very rapid, and they can have a rapid correction and have been reported to develop osmotic demyelination. You can get thiazide-associated hyponatremia even 24 hours after giving a thiazide. You can see that after discontinuation or after saline hydration if they're profoundly hypovolemic. Any rapid spontaneous resolution of SIDH if you're giving DDAVP and suddenly stop it. And you also see this in beer potomania or low solute hyponatremia, where you start giving them solutes and you get a rapid increase in serum sodium. And we have a case that we'll talk about at lunch. In hypopit patients, this is shown very dramatically in patients that were given high doses of glucocorticoid. So these lines are what this AVP was before glucocorticoid was given, and that goes to what the AVP was after glucocorticoid. And you can see this rapid normalization and substantial normalization into the normal range of the curve in patients that were given glucocorticoid. And we had a case at the Brigham a few years ago where the patient was given significant amounts of glucocorticoid, and the sodium went from 110 to 135 in less than a day. So this is very much one case where you can see a rapid correction of hyponatremia. Finally, we're going to talk a little bit about vasopressin antagonists. The two that are available are Conivaptan, which is a V1A, V2 antagonist and is only available IV in the US. Tolvaptan is a V2 antagonist and is available as oral antagonist. Tolvaptan really was approved based on the two SALT trials, which were combined European and American trials and published in New England Journal. Conivaptan has been FDA approved for longer than that. It's not approved for cirrhosis or acute hyponatremia or for primary treatment of CHF. Only the IV form is available. You get infusion site reactions in many of these patients. Overcorrection can occur in about 10%. The reason that it's not available as an oral drug is there are tremendous drug interactions with other interactors with CYP3A4. If you look at the correction of serum sodium with Conivaptan, you can see that you get a really significant correction within the first 24 hours or so. So if you give Conivaptan, you need to be prepared for some degree of overcorrection and stop the drug infusion or give back free water or very rarely give DDAVP. The pros and cons, well, the key issue is what are the clinical indications in clinical practice? And I don't think we really know what the hard and fast indications for these are. They're basically approved for the management of serum sodium and hyponatremia, but we don't really have a good sense of when we should or should not be using these. They're very expensive. Tolvaptan is approximately $200 a day. There is a risk of overcorrection. You can minimize that by frequently monitoring serum sodium during the first 48 hours. You can give Tolvaptan in liver disease. You can't give Conivaptan. Conivaptan is IV but not oral, and vice versa for Tolvaptan. So we're going a little bit over time, but we're going to talk very quickly about hypernatremia. And just to remind you that you can get hypernatremia by increasing the numerator, which is a very rare cause of hypernatremia, or most of the time we decrease the denominator and we have a relative deficit in free water. The water intake disorders or an insufficient water intake, which is very common, particularly in the elderly. A high sodium intake without adequate water is relatively rare. You do see this in very strange forms of sodium poisoning. Occasionally, patients will have osmoreceptor CNS lesions. They will have a stroke that involves the osmoreceptor neurons that we talked about, and they can get primary adipsia and sometimes also with some degree of central diabetes insipidus. This is sometimes due to an infiltrating tumor or granulomatous disease, such as in sarcoid. Ischemia can do it. Primary hyperaldosteronism can also do it, and you see it to some degree as a physiological defect in patients with advancing age. Inappropriately high water losses you can see with insensible losses, sweat and breath, GI losses, vomiting, and diarrhea. One key issue is that secretory diarrhea is typically isotonic, whereas osmotic diarrhea tends to have some degree of free water loss. And you can have, of course, kidney loss of free water in the diabetes insipidus. Renal water loss has three major causes: a central DI due to a decrease in ADH or vasopressin secretion, a renal ADH resistance or vasopressin resistance and nephrogenic DI, and the rare form where you have an increased degradation of vasopressin in gestational DI. Central DI has many, many different causes. One of the more interesting recent causes is patients with IgG4 syndrome, where you have an autoimmune disorder that can affect the pituitary as well as other regions in the body. Classically, we're told of this triphasic response in pituitary surgery. We have initial hyponatremia and then hypernatremia and then hyponatremia. But in fact, many of the patients have most patients have different types of patterns in vasopressin response after pituitary surgery. If we look at a polyuric patient, the key first thing is to look at their osmolar excretion rate. If it's greater than 1,000 milliosmoles per day, that patient has an osmotic diuresis. And we'll talk about a very interesting case at lunch where it was a glucosuria that caused the problem. If it's less than 1,000 per day, this is a water diuresis. And we then look at serum sodium. If it's greater than 140, they have a diabetes insipidus. If it's less than 140, they have primary polydipsia. Nephrogenic DI, we'll talk about this also at lunch. There are many genetic causes: mutations in the V2 receptor, mutations in acroporin 2, or mutations in acroporin 1, because of its role in the proximal tubule, can get you a nephrogenic DI. Drug-induced nephrogenic DI, particularly with lithium, is a very important cause. Hypokalemia will give you a nephrogenic DI, as does hypercalcemia. I think we often see patients, though, after acute tubular necrosis, where as their renal function gets better, you'll see this slight increase in their serum sodium. And if you look at those patients, they'll have a concentrating defect, which technically is also a nephrogenic DI. Gestational DI is very rare, occurs in 1 out of 300,000 pregnancies. This is due to increased expression, release, and activity of vasopressinase that's produced by the placenta. It may occur in the context of preeclampsia and/or fatty liver or pregnancy. DDAVP is resistant to this vasopressinase, so this is an effective therapy, and we have a patient, again, that we're going to talk at lunch with that disorder. If we need to, we do water deprivation testing. If we look at osmolality and in response to water deprivation, we can see patients with a partial central DI or partial nephrogenic DI, or a complete central DI based on their response to vasopressin. And we'll go through this in a particular case at lunch as to how you can do a water deprivation test. The treatment is to restore the water defect, reduce and or replace ongoing loss of hypotonic fluids, to treat the underlying cause, either give them DDAVP for central DI. We'll talk about how you can give NSAIDs or hydrochlorothiazide in some cases of nephrogenic DI. And in gestational DI, the therapy is DDAVP because it's resistant to the vasopressinase. You need to replace the free water deficit. I think this is fair game on the boards that they will ask you to calculate free water deficit, because you can do that to some degree in your head. That needs to be replaced over 48 hours. For patients that have ongoing loss of free water, you need to also calculate their daily losses, and the free water clearance equation is very helpful, as we'll go over in a case at lunch. So patients need half of this replaced in 24 hours. At the same time, you give them their daily losses in free water as well. So cerebral salt wasting syndrome, some people now call renal salt wasting syndrome, because many of these patients not all of them have cerebral disease. So it's a very puzzling syndrome. These patients have clinical hypovolemia with a very high urine sodium in the setting of an acute CNS process, be it subarachnoid hemorrhage or other process. Many people feel that this is really not a disorder. If you look carefully at some of these patients, they actually have SIDH. and have just been given a lot of saline. But this really is sort of, looking at a given patient. If they are inappropriately volume depleted with a high urine sodium, and if they respond to aggressive saline resuscitation with an increase in their serum sodium, you've pretty much made the diagnosis. Some people think that it's helpful to measure urate excretion in these patients. They have fractional excretions of urate that are 30% or more. So the serum urate can be very helpful in patients with hyponatremia to differentiate SIDH from hypovolemic hyponatremia, for example, where urate is high. But in both SIDH and cerebral salt wasting, serum urate is very low, and there can be overlap in the fractional excretion of urate in those patients. There's not a really good convincing data as to what the mediator is. Some people have implicated a brain natriuretic peptide, but there's a proximal tubule defect in proximal tubule salt absorption, which doesn't totally fit with a natriuretic peptide being the culprit.